Welcome, everyone, to our virtual hereditary cancer series. My name is Kelly Metcalf, and I'm one of the scientists in the Hereditary Breast and Ovarian Cancer Clinic at Women's College Hospital. And we're thrilled to be able to bring you this virtual series. As many of you know, we have traditionally held this in person, but because of COVID, we've had to rethink things. And I actually think it may be beneficial because we're able to reach more women who could benefit from this information. As you know, at Women's College, we have been collecting data from women with a BRCA1 or 2 mutation for over 20 years now. And we have research information from over 17,000 women. And this helps us to answer many of the important clinical questions that are important to women like you. And this is what we're aiming to do in this virtual cancer series, is to bring that information back to you as a thanks for your participation in our research program and to keep you current on the latest research that may inform your clinical care. So as I would encourage you, if you're not part of the risk factor study, to register for this study. It's very helpful in helping women like yourselves, your family members, and other women who may have a BRCA1 or 2 mutation. So I'd like to hand it over to Joanne Katsopoulos, one of the other scientists here in the Hereditary Breast and Ovarian Cancer Clinic, and she will get us started in today's session.
Thank you, Kelly. Hello, everyone. We're really excited to be offering this virtual series. It's our first session, so bear with us as we figure out the logistics of the next hour. But I'm very excited to be here representing our large team and really sharing some of the information that may even stem from the information you've provided if you are a participant in our study. And I'm here to introduce Dr. Michelle Jacobson. And she's going to be providing some important information about the management of menopause after prophylactic oophorectomy. But before she starts her presentation, I would like to read a little biography of her in case you don't know her already. So Dr. Jacobson is a general OBGYN and menopause specialist at Women's College Hospital and Mount Sinai Hospital here in Toronto. She has a special interest in women who are prematurely menopause due to cancer therapies and women with hereditary cancer syndrome, such as women with the BRCA1 or 2 mutation. Importantly, and she plays a very important role here at Women's College Hospital in that she directs the Familial Ovarian Cancer Program, and she received her medical degree from Western University. She did her residency in menopause management at McMaster University and her fellowship and master's in translational research here at the University of Toronto. So Michelle, we're very excited to hear all about everything you have to offer for us today. And just to orient you to our Zoom question and answer period. So this is going to be a little bit different than what we would have done if we were live in an auditorium. We want you to think about what questions you might have for Michelle and type them in the chat box. I think it shows up as a chat box for you. And Dr. Metcalf and myself will try to navigate the questions. We're going to have about 15 minutes for questions. So we'll have Michelle answer some of the key questions or maybe the recurring questions that arise. And Dr. Jacobson has kindly offered to continue to answer some questions as she can for a little bit of time after in the chat box when she finishes her presentation after 1 o'clock. So hopefully that's clear. So Dr. Jacobson, I'm going to stop sharing my screen and we're excited to hear your presentation.
Thank you so much, Joanne. Can everyone hear me okay? Yes, perfect. And thanks, Kelly. And really thank you, everyone, and to the Gilgan Foundation for putting this together. This is a presentation that we've done through the Women's College Research Institute in the past and now have some additional support, which is fantastic. It is a very, when I've presented this in the past, I've really made it very understandable for patients because that was primarily our audience. We've got a larger audience this time that includes lots of clinicians as well. So for people who are a little bit maybe unable to understand what some of the information on the slide says, I'm going to try and really explain things. So just focus on what I'm saying rather than what you're seeing necessarily. And I'll warn you that we're going to show a video of us doing one of the surgeries. So if anyone is squeamish or eating their lunch and doesn't have the usual conversations that I have around the dinner table, then feel free to skip it for 2 minutes, maybe when I start showing that video, and I'll give you a warning. So we're going to talk a little bit about menopause management in BRCA 1 and 2 deleterious variant carriers. Okay. Perfect. So these are my disclosures. So the objectives of this session are to review the recommendations for risk reduction in BRCA1 and 2 mutation carriers, recognize some other actionable ovarian cancer genes, so women who have been diagnosed with a genetic mutation that recommends that they undergo prophylactic risk reduction oophorectomy, but not necessarily BRCA1 and 2, discuss the evidence around menopause management for women who are unaffected, which means haven't had breast or ovarian cancer, BRCA carriers who have gone through premature menopause, and to describe some of the options for treating women who have had breast cancer and who may have different needs when it comes to treating their menopause. So first of all, what is the risk of developing ovarian cancer if you are a BRCA1 or 2 mutation carrier? The risk of ovarian cancer, and when we say ovarian cancer, we're talking about tubal and ovarian cancer, as well as peritoneal cancer. So we think of these three cancers that look very similarly under the microscope as being all part of the same disease. And the actual diagnosis of what type of cancer you have sort of depends on which body part gets looked at under the microscope first, or how the which part of the body has been affected, but these all tend to act and look very similarly. So in BRCA1 mutation carriers, the risk of tubal, ovarian, and peritoneal cancer, which we're going to call ovarian cancer, in your lifetime is about 44%, and in BRCA2 carriers, about 17%. So we tend to think of it, to remember things easily, as about 50% and 20%. The risk of breast cancer in both of these mutations is a lot higher, again, anywhere sort of between 65 and 85%. So we think of it in the realm of 70 to 80%. We see here, if you look at these graphs, that the risk of breast cancer increases from about the mid-20s in BRCA1 and 2 carriers and tends to sort of increase and plateau after about 60. So if you haven't gotten breast cancer by 60, your risk per year of getting breast cancer doesn't continue to necessarily increase after 60 significantly. That's a little bit different than the risk of ovarian cancer. In BRCA1 mutation carriers, the risk of ovarian cancer starts to increase significantly above the general population's risk at age 35. It tends to plateau at that 50% risk by about age 70, but the risk doesn't then go down. And similarly, in BRCA2 carriers, the risk starts to increase above the general population's between 40 and 45 years and reaches its maximum by 70, where it also does not decrease after age 70. These are some of the other genetic mutations that you may have been diagnosed with, or you may recognize or read about. ATM is a genetic mutation that has a potential for increase in ovarian cancer risk, but currently does not have enough evidence to recommend risk-reducing surgery, whereas it does have an increased risk of breast and colon cancer. BRIP1 has an increased risk of ovarian cancer in the realm of about 10%, tends to be a slightly later onset. So we recommend surgery between 45 and 50 for these patients. Similarly, RAD51B, C, and D. STK11 is a little bit of a different kind of ovarian cancer. So those surgeries are recommended later, and there's a little bit more screening because of different types of gynecologic cancers that these women get. And in the Lynch syndrome, women are at increased risk for ovarian cancer, as well as uterine and colon cancer, and breast, depending on the type of mutation. So those women are actually recommended to have a hysterectomy, as well as tubes and ovaries removed upon completion of childbearing, as early as 35 as well. What are some options for ovarian cancer risk reduction? So women who have had surgery to reduce their fertility, like tubal ligation or removal of the fallopian tubes, have a lower risk of tubal and ovarian cancer than women who haven't. In the general population, so in non-BRCA mutation carriers, we know that risk is about 30 to 40%, and that has been repeated and demonstrated in the BRCA carrier population as well. So we know at worst, removal of fallopian tubes is as good as tubal ligation, and we'll call that about a 30% risk reduction for counseling purposes. We'll talk a little bit later about whether salpingectomy, which means removal of the fallopian tubes, is as good as removing the ovaries, and if that provides optimal risk reduction. The spoiler alert is that we don't have data to tell us that. But when we think about risk reduction from tubal removal, we can confidently say that it's at least 30% good enough. We're taking birth control pills, so oral contraceptive pills, for more than 5 years has also been shown to reduce the risk of ovarian and tubal cancer, both in carriers and in non-carriers, as well as women who have breastfed, depending on the type of carrier that they are, number of pregnancies, depending on the type of carrier, and having had a hysterectomy, even if the tubes and ovaries were not removed for other reasons, seems to also decrease the risk a little bit. The National Comprehensive Cancer Network is an American organization, and they, you know, give us recommendations on what age to treat women for prevention of cancers. I tend to follow their recommendations because within Canada, the healthcare is distributed provincially, and every province has different rules about who can be tested for BRCA. But it's nice to have one set of recommendations to follow that are national. So we follow these NCCN guidelines. They recommend the decision to undergo a risk-reducing salpingo oophorectomy, which means removing the tubes and ovaries for prevention of ovarian cancer, is complex, and they suggest that ideally this should be made in consultation with a gynecologic oncologist. There's no doubt that gynecologic oncologists are very equipped to counsel women around this. Within our clinic, we also, of course, have specialists who are gynecologists who are not necessarily oncologists, who are also well equipped to counsel women around these complex decisions. And when we see women at any point in their reproductive life to talk about their risk for tubal and ovarian cancer from being carriers, we discuss their impact on fertility and reproduction, the impact that taking the tubes and the ovaries out, or the risk of ovarian cancer, on breast cancer risk, on ovarian cancer risk, and what the complications or the way you might feel after having your tubes and ovaries removed might confer. So quality of life issues and the risks associated with premature menopause, particularly bone problems like osteoporosis, early cardiovascular disease, changes in memory, focus, concentration. We call those cognitive changes. Hot flashes and night sweats, so those are vasomotor symptoms. Mood changes like irritability, trouble with sleep, depression, anxiety, changes in libido, so sexual appetite, changes in sexual functioning, so whether sex is painful, if you have trouble with arousal or with orgasm, and changes in body image, particularly for women who have undergone mastectomy preventively or from breast cancer plus or minus reconstruction. So we try and address all of these issues when we counsel women in our clinic. And depending on where a woman is at in her reproductive life, the discussion pieces are a little bit different. So there's a very big difference between, discussing the timing for contraception, fertility care, and timing of surgery in a woman who's just found out at age 20 that she's a carrier, compared to somebody who may have found out incidentally at the time of a breast cancer diagnosis in her 70s. So taking out the tubes and ovaries, what does that do to the risk of ovarian cancer in women with a BRCA1 or 2 mutation? So this was a study that came out of the women's group, with Amy Finch being the lead author. And it followed women who'd had their tubes and ovaries removed, almost 6,000 women. And this is where we get this sort of recommendation that by taking the tubes and the ovaries out, the risk for ovarian, tubal, and peritoneal cancer is decreased by 80 to 90%. Now, importantly, there's also a significant decrease in all-cause mortality. So that means that women who take their tubes and ovaries out preventively, who are carriers, are less likely to die from all reasons, not just from ovarian cancer. And that gives us a lot of hope that by taking the tubes and ovaries out, we're not doing more damage just for reducing the risk of ovarian cancer, that women are also going to get a mortality benefit. So they might live longer or die less earlier because they've had the surgery done. The recommendations are that women should consider taking the tubes and ovaries out in the circumstances by which they're a carrier. So this only applies to women who are BRCA1 and BRCA2 carriers. And we recommend that surgery be performed between ages 35 and 40 for BRCA1 mutation carriers, and between 40 and 45 for BRCA2 mutation carriers. Now, where do these age ranges come from? So if you were to take out the tubes and ovaries of every BRCA1 mutation carriers at age 35, you'd find cancer about 1% of the time. And that's the general population's risk of developing ovarian cancer. We certainly don't run around on the street pulling every woman into our offices to take their tubes and ovaries out because of a 1% risk of cancer. But if you do the surgery again at age 40, you'll find cancer 4 to 5% of the time. So, sometime between 35 and 40, the risk for ovarian cancer increases to about 5 times the general population's risk. And that's where these age range recommendations come from. For a BRCA2 mutation carrier, the risk at age 40 is about 1%, and the risk at age 50 is about 4%. So, sometime around 45, we think, is the optimal time to perform these risk reductive surgeries. But if you're trying to maintain the population risk, that would be at age 40. So, between 40 and 45. How do we do this surgery? So we do the surgery laparoscopically, if we can, which means 4 small incisions that are each about 5 millimeters in size. The largest incision is made in the belly button, and that is about 1 centimeter in size. When we do the surgery, we do something called inspection of the abdomen. So we look at the liver, the diaphragm, the sides of the pelvis, the colon, and all around the pelvis, behind the uterus, in front of it, on the bladder surface, looking for any sign of cancer anywhere. Then we do something called pelvic washings, which means we put fluid into the cavity of the pelvis. We suck that fluid back and we send it for something called cytology, which means that a pathologist looks at it underneath a microscope, looking for rogue cancer cells. So that would maybe inform us that somebody had a cancer that was so tiny it may not have been seen, but may have cells floating around that are atypical or abnormal. And that patient would be at much higher risk for developing peritoneal cancer after their surgery. We do the surgery by isolating the IP ligament. So that's the blood supply to the ovary. We want to isolate that at least 2 centimeters, if not 3 centimeters away from the ovary, to ensure that if, God forbid, there was any cancer in the ovary, that we have very clear margins, and to make sure that there's no ovarian tissue that we can't see with our eye any closer to the pelvic sidewall than the ovary itself. We remove the tube right at the uterus, and we go a little bit into the uterus to do that so that we can remove the entire portion of the tube for women who are keeping their uterus behind. We put the specimens into a bag. So we're not going to put the specimens and pull them out through the incisions and potentially seed microscopic cancer cells into the skin or the abdominal wall. We put them in a bag to remove them. And most importantly, we make sure that our pathologists know that these patients are carriers of BRCA1 or 2, and that the protocol that needs to be done for looking at the fallopian tubes is special. It's called the CFIM protocol, and that's sectioning and extensively examining the fimbriated end of the fallopian tube. And the reason we do that is when this particular technique is done, more very small stage 0 cancers called STICs, so serous tubal intraepithelial carcinomas, can be found. They're not found when the tubes are looked at in the normal fashion, the way a pathologist would normally examine a fallopian tube. So it's very important that the pathologist knows to cut the fimbria, so the end of the fallopian tube, up into really tiny little pieces longitudinally, and look very carefully for these stage 0 microscopic cancers, because the treatment of the patient changes and the prognosis changes based on whether there is one of these stick lesions found. So this is the video that I wanted to show to everybody. So I'll pause for just a minute in case anybody wants to not see it. And I'm just going to skip through this. The person who is annotating the video is one of our former fellows, so it's not my voice. But this is a video that we submitted to the Society of OBGYNs of Canada a couple of years ago to show other gynecologists how we do this procedure specifically for BRCA carriers. So I'm going to press play now.
Steps in detail. The first step is the careful and thorough examination of the entire abdomen with biopsy of any suspicious lesions. The patient is placed in steep Trendelenburg and pelvic washings obtained by gently irrigating over the adnexa. We use a uterine manipulator for the surgery. Identification of both ureters is essential for the safe completion of the surgery. Here we can see the left ureter undergoing peristalsis just below the IP ligament. We then confirm the location of the right ureter as well. We start the next step by identifying the safe triangle in the broad ligament that is bordered by the round ligament, the IP, and the external iliac vessels. This allows us to enter the broad ligament in this safe location. We start by tenting it up and incising it sharply. This incision is then extended sharply towards the uterus and along the IP ligament. Our surgery can be performed with both bipolar and cautery and scissors, or with an advanced bipolar device. Even when we perform it with an advanced bipolar device, the principles of anatomy and creation of our broad ligament window should be followed. A small opening is then made just below the IP ligament and above the ureter. This opening can be extended with sharp dissection as seen here, or bluntly with 2 instruments. With this technique, we are able to ensure that the ureter is protected as it is located below the window, and also isolate the 2 main vascular supplies to the ovary. We then proceed with coagulation and transection of the uterovarian ligament just adjacent to the uterus. Just as it is important to completely remove the distal tube and fimbria, it is important to coagulate here and ensure the proximal portion of the fallopian tube is removed in its entirety. Care should be taken here not to incise the uterus, as this can lead to unnecessary and excessive bleeding. The only attachment that now remains is the IP ligament. The newest recommendations is to ensure that the IP ligament is cut at least 1 to 2 centimeters from the ovary. In this view, we are able to again see the ureter undergo peristalsis and the close proximity it has to the IP ligament. We then proceed to use 2 endoloops across the IP ligament. Following placement of the second endoloop, we will cut the IP ligament. At this step, we often see backflow bleeding. This bleeding quickly stops. The specimen is then placed either in the posterior anterior cul-de-sac, and gentle irrigation and suction is used to confirm hemostasis along our dissection line. We then proceed with the same procedure on the opposite side. Once both specimens are removed, we use an endo-catch bag and remove the specimens through the umbilical incision. The use of the endo-catch bag is necessary to prevent shedding or port site contaminations in cases of occult malignancy. Proper pathological assessment of the adnexa is essential in identifying occult, pre-malignant, and malignant disease. This video will provide an up-to-date.
Great. So this is the same picture you just saw with which goes over the CFIM protocol. And again, that's going to increase the detection of any stage 0 tiny fallopian tube cancers from 2.5% if the pathologist looks at the tube in the usual way to 17%. So that means looking at the tube in the usual way will miss fallopian tube cancers by about 15%. So it's very, very important that pathologists are aware of the fact that your patient is a carrier of the mutation. And second of all, that your pathologist is trained in how to do this protocol so that they're able to do it correctly. So what about the fallopian tube? This is something that obviously comes up a lot because a lot of us are reading, and we know that there are theories out there that the fallopian tube is actually the source of these ovarian cancers. And perhaps we're all hopeful that if we're able to take out the fallopian tube only, we wouldn't have to subject women to the risks and the problems associated with premature menopause. We could just remove the fallopian tubes. Now, it's not that clear because we don't have good evidence yet, and hopefully we will at some point in the future, but we don't have clear evidence yet that the fallopian tube is the source of the abnormalities and the cancers that arise in this pathology. So at least 50% of the types of cancers we see in our BRCA mutations are actually from the end of the fallopian tube. The problem is that the fallopian tube and the ovary sit right on top of one another. And in studies that have been done looking at removing the tube, followed by removing the ovary in non-BRCA mutation carriers, we actually see lots of residual tissue from the fallopian tube that's microscopic, that's still attached to the ovary, even if the tube was removed separately. We know that the lifetime risk of developing fallopian tube cancers in the BRCA mutation population is at least 0.6%, which is higher than in the general population. But we think that this risk is vastly underestimated because, for the most part, when women present with disseminated or metastatic cancer, it's impossible to tell where that cancer started from. It's only with programs such as ours where women are having surgery preventively and cancers are being found at very, very early stage that we really start to see the timeline of these cancers starting in the end of the tube as a non-invasive cancer and then proceed past the membrane of the tube and become at least a stage 1 tubal cancer. But sometimes we still see cancers that are isolated to the ovary only. So it's not as clear cut as it always starting in the fallopian tube. So should we do risk reducing salpingectomy? That means removing the tubes only and leaving the ovaries behind. Well, there was one really interesting statistical study that was done out of the Netherlands where they said, we don't know if it's best case scenario taking the tubes out is as good as taking out the ovaries. Let's call that 90% effective. But we do know that in the worst case scenario, taking the tubes out is about 30% effective because we have that data from both the BRCA and non-BRCA populations. So in the best case scenario, if we assume that women are likely to get cancer by age 40 in BRCA1 by about 5%, and by about 50 in BRCA2 by about 5%, is there any statistical difference in the likelihood that somebody would die from tubal and ovarian cancer if you did this delayed oophorectomy? So RRS with delayed oophorectomy means taking out the fallopian tubes and 5 years later taking out the ovaries. What they found in the statistical model is that it didn't make a difference in terms of the statistical risk of dying from ovarian cancer if you took the fallopian tubes out at age 35 in BRCA1 and 40 in BRCA2, and then the ovaries out at age 40 in BRCA1 and 45 in BRCA2. The problem is you're subjecting yourself to 2 surgeries and buying 5 years of additional time with your ovaries under both case scenarios, but we don't have proof that doing this is actually effective. We only have these statistical models, and we really only offer taking the tubes out alone in women who are under the age of recommendation, but have completed childbearing and want to do something preventive, or in women who sort of accept that this is experimental, but are unwilling to have the ovaries removed yet and want to feel that they're doing something. There are large studies that are being done around the world in the Netherlands and the States and France, and we're going to participate as well, that actually look in a very mathematical and scientific way at removing the fallopian tubes and followed by taking the ovaries out 5 years later to see what the actual risk of developing ovarian cancer is in that time. But currently, the recommendations are to only take the fallopian tubes out for prevention in an experimental or research trial way. This picture you see on the right here is the progression in different pathologic stains. So this is what the pathologist would see by looking under the microscope. And what you can see is normal tubes on the left-hand side. The second column is what happens when there's a genetic abnormality seen called a P53 signature, which might signal to the pathologist that this tube is going to have abnormal DNA and become abnormal. Then you get this tubal intraepithelial carcinoma, which means that there are cancer cells there, but they haven't invaded through the membrane or the outside part of the fallopian tube. And then in the last column, you see disseminated cancer. So that's what cancer looks like under the microscope when it's actually passed all the way through the fallopian tube. So back to what we can do for risk reduction. Well, we know that by taking birth control pills, we can decrease the risk of ovarian cancer when the pills are taken for 5 years by about 40%. Now, people will always wonder, what is the increased risk in breast cancer from the prolonged exposure to high levels of hormones? Well, we think, based on studies that Dr. Katsopoulos has done, among others, that the risk for breast cancer is highest in women who are BRCA1 carriers and under 25 when they've taken their birth control pills, if they've used birth control pills for more than 5 years total, or if they were using high-dose pills prior to 1975. I always get people worried, well, I've done this, right? I didn't know I was a carrier, and I've been taking birth control pills since I was 14 or 16, or I was recommended to take birth control pills for other reasons. Have I put myself at risk? I think what's really important is to remember that there's very little that can be done to reduce the risk of ovarian cancer, and ovarian cancer can't be screened for. So, if anything, you are doing yourself a huge favor by taking a birth control pill without any other contraindications if it's been important to you for many reasons, like reducing abnormal cycles, protecting you against an unwanted pregnancy, or even specifically for the use of reducing your risk for ovarian cancer. When your risk of breast cancer is baseline very high, and it is for our BRCA1 and 2 mutation carriers, you have to wonder if taking something like a birth control pill, which does increase the risk over baseline, but only slightly, matters when the risk is already so high to begin with. So I always say to people, if your risk was already 70 or 80%, and I told you that something you could do might increase your risk by 5% or by 10%, or even lower your risk by 5% or 10%, does it really matter when it comes to making decisions when the numbers are still so high? When you think about doing things that are going to reduce your breast cancer risk, you want to do things that are going to have a significant effect on reducing your breast cancer risk, not a small effect when the baseline risk is high. What about taking the uterus out? People are always asking that because, first of all, people worry that they might be at increased risk of getting uterine cancer. So, several studies have been done, most recently, a large review out of Montreal looking at the risk of uterine cancer in BRCA carriers. Overall, it doesn't seem that there is a significant increased risk, which means a statistically important increased risk of overall endometrial cancer, which is the lining of the uterus, in carriers. There is a slightly higher than expected rate of a cancer called papillary serous carcinoma in BRCA1 mutation carriers. Again, that has not been found to be significant. And there's also a lot of crossover because those cells under the microscope look a lot like fallopian tube, peritoneal, and ovarian cancer. They have the same type of look to them. So it's hard to know if those cells actually originate in the uterus versus maybe in the part of the tube that's a little bit closer to the uterus. Overall, there isn't a recommendation to remove the uterus just for being a carrier. There are some cases where women want to have their uterus removed because they have other gynecologic indications to remove their uterus, like fibroids, or they've had high grade cervical cancer cells seen in the past, or they have significant prolapse. Some women who take tamoxifen, either for prevention of breast cancer or for treatment of breast cancer, want to have their uterus removed because the risk of endometrial cancer with tamoxifen use is increased about 3.5 times over the general populations. Overall, about 157 hysterectomies have to be done in BRCA1 mutation carriers to prevent one case of uterine serous cancer. Overall, we don't recommend that women have their uterus removed just for being a BRCA mutation carrier. I have a 3-year-old knocking at my door. It's locked. And what about hormone replacement therapy? So if women have their uterus removed, that actually makes my job as your menopause specialist a lot easier. So when we give hormone replacement therapy, we give estrogen therapy to help women with symptoms and to help women with protection of their bones, brain, and heart. We give women progesterone or progestogens because when we give estrogen, the lining of the uterus becomes overgrown, and we need to give a progestogen to clear the lining of the uterus and stop it from becoming cancerous. That's not related to being a BRCA mutation carrier. That's for women in general. If women take too much estrogen with no progesterone, overall, we expect that they will develop an overgrowth in the lining, and they need progesterone in order to keep that lining from becoming overgrown. We don't think it's necessary to do a hysterectomy just for hormone replacement therapy simplicity because there are other ways to mitigate the risk of endometrial cancer. There are medications out there that are hormone replacement therapy drugs that don't use any progesterone in them. One of them, which many of you may have taken in the past, is called Duaviv, and we had a lot of success with that medication. The problem is it's currently been on back order because of a manufacturing problem for the last about 9 months now, with no clear end in sight of when it's going to be back. Similarly, when we give hormone replacement therapy, we can give it in such a way that the uterus is protected while minimizing the patient's risk for taking progesterone. And this becomes important, and we'll talk about it a little bit later, because we know taking estrogen alone does not seem to increase the risk of developing breast cancer in women who are carriers and in women who are not carriers. But women who've also been exposed to progestogens in the past may have a very slightly increased risk of developing breast cancer. The reason that you need to take that information with a grain of salt is the type of progestogens that were used in those studies is one that's not great for the breast at baseline. It causes a lot of abnormalities in the breast. But since then, there's lots of newer medications that have become available that seem to be a lot safer when it comes to breast cancer risk. So what happens when we take your ovaries out? You have an abrupt and early surgical menopause. You might get hot flashes and night sweats, changes in sexual function, changes in mood. In women who are not carriers, the overall risk of dying increases by having the ovaries out. But in women who are carriers, we know that overall their all-cause mortality actually decreases by having the ovaries out, and not just their risk of dying from ovarian cancer. So this is a population that is very unique in that taking the ovaries out actually lowers your risk of dying from other reasons. Women also have an increased risk of cardiovascular disease, of osteoporosis, and of cognitive impairment if they go through menopause too early, with every year below age 45 conferring a significantly increased risk of these diseases. The good news is that all of these diseases can be improved by giving hormone replacement therapy. The bad news is that many of our patients only find out that they're carriers because of an early breast cancer diagnosis. And having a breast cancer diagnosis is a contraindication to taking hormone replacement therapy, which means women who've had breast cancer in general are not supposed to take hormone replacement therapy because the risk of their breast cancer is increased for returning. So what are the sort of specific things we think about when giving menopausal hormone therapy to BRCA carriers? First of all, a lot of women are very fearful of taking hormone therapy at baseline, and particularly women who are high risk for breast cancer. It's hard to assess the risks of developing, the risks of taking hormone replacement therapy to mitigate the problems from early menopause, particularly when women are worried about the risk of breast cancer. There are some statistical models that have been done that have looked at what's the best way to make somebody live longer. And what they found is that in BRCA carriers, having the breast removed and having the ovaries removed preventively, even as early as age 30, plus taking hormone replacement therapy to age 50, gives you almost 1 year extra of life. Now, that's a very old study, and there are a lot more factors that go into it. But I think the point here is that by doing preventive surgeries and being able to take hormone replacement therapy, you are doing yourself a favor. Where we really have to think carefully is of our patients who can't take hormone replacement therapy, and that becomes a much more difficult decision in terms of timing of when to take the ovaries out. Does hormone replacement therapy cause breast cancer? And similarly, does taking hormone replacement therapy after taking the ovaries out increase the woman's chance of getting breast cancer after a possible decrease from her oophorectomy? So we have a couple of studies. One was done out of a group in Toronto, out of Sunnybrook. They looked at 400 women who used hormone replacement therapy who were BRCA1 mutation carriers. And they found overall that the likelihood of developing breast cancer with women who'd ever taken hormone replacement therapy was not elevated. So no increased risk of breast cancer in carriers after hormone therapy use. Similarly, a group out of the States, Tim Rebick is a big researcher in BRCA, found that even for women who had had their ovaries taken out in order to reduce the breast cancer risk, and this is particularly true for BRCA2 mutation carriers, taking hormone therapy does not return that risk back to baseline. So if you've taken your ovaries out and made a decision to take the ovaries out partially because you're hoping to reduce your breast cancer risk, taking hormone therapy does not take your breast cancer risk back to baseline. You still have a benefit from removing the ovaries. The problem is that the only women who seem to benefit from having their ovaries removed in terms of breast cancer risk are women who are BRCA2 mutation carriers and premenopausal. So this is not true for BRCA1 mutation carriers. From the literature that we have, taking the ovaries out does not seem to change the rates of breast cancer in those patients. Now, Joanne, myself, Stephen Nayrod, a number of us did a study looking at taking hormone replacement therapy after oophorectomy to determine if there was an increased risk of breast cancer in BRCA1 mutation carriers. This looked at women over about 7.5 years, almost 1,000 women who'd undergone risk-reducing salpingo oophorectomy with a sort of average age of about 43. And what we found, I'm just going to bring these up, is that in the women who were taking only estrogen, there was no increased risk in breast cancer compared to women who had taken nothing. Unfortunately, women who had taken estrogens with progestogens did have a slightly increased risk of breast cancer compared to the women who had taken estrogen alone, but overall, this was not significant. So the overall conclusion of the study is that estrogen is better than estrogen and progesterones if possible, but taking estrogen plus progestogens does not significantly increase risk of breast cancer in this population. And again, all of this data was colored by the fact that most of it is based on women who were taking medications that we don't typically use anymore and are not great for the breast. So it begs the question that if you were to pull out all the women who were studied here and only look at the ones who take the type of hormone therapy that we currently prescribe, would you even see an increased risk of breast cancer in the combination HRT group? We don't know, but based on studies in non-carriers, we think likely not. The other thing to remember here is that the type of estrogen women were taking for the most part was conjugated estrogen. So that goes by the trade name Premarin, and it was the most common type of estrogen that was used at the time where these women were studied. There are lots of other estrogens that are available and on the market now, but the Women's Health Initiative study, which was published in 2000, recently had its results updated over 20 years. And what they found is that women who were taking conjugated estrogens, or Premarin, had an overall lower risk of breast cancer, again by about 20%, even over 20 years. We can't necessarily say the same for women who are taking estradiol, which is estrogen by patch or estrogen by gel. So we know that taking conjugated estrogen lowers breast cancer risk in general, but taking estrogen through the skin or by mouth that's not conjugated estrogen may not have that same benefit. That's not to say that it's risky, but it may not be protective against breast cancer like taking conjugated estrogen is. And all of these things are taken into consideration when we give you a prescription for hormone replacement therapy. And that's why these discussions sometimes take a really long time. And there's a lot of tweaking once you've started your hormone replacement therapy, because we have to balance your symptoms, your risks, and the right regimen of hormone therapy for you. Does HRT cause ovarian cancer? Joanne says, no reason to think so. Perfect. Does hormone therapy work? It works well for vasomotor symptoms. It works well for overall quality of life and well-being, but there is a little bit of controversy over whether it works that well for sexual symptoms. There are lots of HRTs out there. There's one that's recently become available in Canada that actually does have data for improvement of sexual functioning for women in general, not necessarily for carriers. But in general, the type of hormone therapy we normally prescribe doesn't have a significant impact on sexual symptoms. The International Menopause Society recently came out with recommendations on how to use testosterone in women who are suffering from low libido in menopause, and that's something that we sometimes do in the clinic. The use of testosterone confers an additional number of satisfying sexual encounters of about 1 to 2 per month. And that may sound like a lot to some of you who may not have had sex in a couple of years. That may sound like very little to some of you who are already having sex 3 or 4 times a week. So again, all this care is very individualized, and testosterone therapy is not for everyone, but it is an option in the hands of somebody who knows how to prescribe it. So again, this is a study that we published earlier this year that looked at the effect of taking the tubes and ovaries out in BRCA1 and 2 mutation carriers on menopausal symptoms and on sexual functioning, and very similar to results to the ones that we just talked about. So women who take hormone therapy have less menopausal symptoms and better sexual functioning, even after follow-up of 3.5 years on hormone replacement therapy. Now, it's not all doom and gloom for women who are not able to take hormone replacement therapy. It just means that we need to be a little bit more creative. So if you've had breast cancer and you can't take hormone replacement therapy, There are a number of reasons that you're going to choose to have your ovaries removed, and there are a number of options of medications and lifestyle modifications you can make, which will help your menopausal symptoms. So when you decide to take your tubes and ovaries out, if you've had breast cancer, part of your reasoning is going to be to lower your ovarian cancer risk because you're a carrier. And part of your reason is going to be that in general, taking the ovaries out improves prognosis for breast cancer. So in women who are premenopausal when they get breast cancer, and it's an estrogen receptor positive breast cancer, there are recommendations to put that patient into menopause, whether that's chemical or surgical, to improve their breast cancer prognosis. So this is going to be more common in our BRCA2 mutation carriers who get a breast cancer diagnosis before age 40. If you're already recommended to go on chemical suppression like Lupron or Zoladex, you may choose to have your ovaries removed as part of your breast cancer treatment so you don't have to go for those injections. It's going to achieve the same thing in terms of breast cancer risk reduction. And by the time you would have come off of your Lupron or your Zoladex, you probably would have been in the age range to have your ovaries removed for ovarian cancer risk reduction anyway. For women who are triple negative, and that's going to more commonly be seen in our BRCA1 mutation carriers, we know from studies that Stephen and Joanne have done that taking the ovaries out within a couple of years of a triple negative breast cancer diagnosis improves overall mortality for those patients and risk of recurrence of that cancer. So there are also prognostic and mortality benefits to taking the ovaries out when you've had triple negative breast cancer, even though it's not a hormone sensitive breast cancer. This is all aside from the benefit of taking the ovaries out for reduction of risk of ovarian cancer. Now, when it comes to treating your symptoms, we can't use hormone replacement therapy in general, but we can use other medications for women who are having bad hot flashes and night sweats. SSRIs and SNRIs are a type of antidepressant, and there are certain medications within that category that at low dose are not used to treat mood necessarily, but can be very helpful for hot flashes and night sweats. The most common ones you're going to see used are venlafaxine and desvenlafaxine, and they do tend to work about as well as a very low dose estrogen replacement. Gabapentin is a medication many of you have taken after your breast removal because it can be used for chronic pain. And the reason it works is in the brain, there are GABA receptors. We know that hot flashes start in the brain. So gabapentin works well, again, about as well as a very low dose estrogen supplement to reduce the risk, to reduce the frequency and severity of hot flashes. The problem is gabapentin can be quite sedating. So it's best used in women who are suffering primarily from night sweats because you can take a healthy dose at night and get less night sweats and more sedating effects to sleep. But if you take it during the day, you may feel sedated. Clonidine is an old blood pressure medication that doesn't work quite as well as the other two that we just talked about, but it can also be used for hot flashes as well in women who have normal or high blood pressure. And oxybutynin is an old bladder drug that's recently been sort of relooked at in terms of the rates of reducing hot flashes and night sweats. And they've shown that it's effective to reduce hot flashes and night sweats at a low dose, both in breast cancer patients and in non-breast cancer patients. The side effects are typically a dry mouth, maybe a little bit of sedation, maybe a little bit of constipation. So again, you want to pick your medications very specifically for a patient and her individual circumstances. I'm going to cut it off now so that we can go through the rest of our questions, I think. But what I want to just mention to you briefly is that taking the ovaries out does increase your risk for cardiovascular disease and for osteoporosis, but that most of those problems can be mitigated by taking hormone therapy or by living as healthy a lifestyle as possible and lowering the other risk factors women can have for cardiovascular disease and for osteoporosis. So taking vitamin D is important. Taking dietary calcium, 3 to 4 servings daily, doing as much exercise as possible. These are all going to be really helpful for reducing your risk and really quite safe in general. So in general, we recommend a multidisciplinary or interdisciplinary care where you're speaking to a number of physicians and allied healthcare professionals who understand where you're coming from and who are able to communicate amongst each other so that you're getting one clear statement. And that's something that we try our best to do at Women's by working within the sort of hereditary breast and ovarian cancer clinic and working with each other. We recommend appropriate screening, chemo prevention, which means taking tamoxifen if you want to for breast cancer prevention, taking birth control pills for ovarian cancer prevention, having your breast risk mitigated either with mastectomy or by doing careful screening to ensure that if you do get a breast cancer diagnosis, it's picked up early. But importantly, you need to remember that screening does not reduce your breast cancer risk. It will just pick it up early. And if you get a breast cancer diagnosis, you will now have a forever contraindication to taking hormone replacement therapy. So there are implications to a breast cancer diagnosis, even if your prognosis for breast cancer is good. We want to plan risk-reducing Fallopian oophorectomy for BRCA1 patients at 35 and BRCA2 patients at 40. But it's important to know what lies after menopause and have a plan on how to mitigate those side effects. We want the appropriate surgical procedure to be done and the appropriate pathologic examination. And we want to be clear that all women who have no contraindications to hormone therapy should be offered hormone therapy. There is a Society of OBGYNs of Canada guideline that can be accessed if you want to read sort of more about this, where most of this information has been put into writing, as well as Cancer Care Ontario guidelines that we wrote earlier this year that have similar information. And I really thank you for your time. This is some information about the next webinar that Dr. Eisen, who is the author of some of the studies I presented to you today, is going to be talking to you about PARP inhibitors for the prevention and treatment of hereditary breast and ovarian cancer on February 19th.
Michelle, that was amazing overview of a lot of information, and I know this will be available for you to review again at your own leisure at home. So we will be posting this presentation and I think the associated slides. So in case you have some information with respect to what Michelle was speaking about. But we're going to try to answer some of the questions that have come up in our question and answer chat box. I'm sorry if we can't get to all the questions, but we will do our best to try to answer some of the more recurring and more general questions that we have here. So Michelle, I'll start with one about, there's one important question about women who had their ovaries removed quite a while back when maybe the CFIM protocol wasn't available, or for this indication of removing tubes at the same time. So do you want to talk a little bit about timing of surgery and whether some of these women it might be worthwhile going back to their clinicians? Oh, unmute. Michelle, we can't hear you.
So that's hard because really the CFIM protocol only started being done really routinely for carriers maybe in the last 10 to 15 years. We don't really know, if you didn't get your pathology done in that way, what your risk of peritoneal cancer is. Overall, I think it's important to remember that the risk of peritoneal cancer is low in general. There are varying ways that stick lesions, these stage 0 cancers, are treated. So for many women, they would be offered nothing any differently than if they didn't have one of these stick cancers, depending on the gynecologic oncologist that you see. There's really no clear guidelines on how to treat these. So I think you have to accept that there's no way to go back and have your pathology re-looked at again because they don't keep the slides that long, but know that you still did a major procedure to overall reduce your risk, and the risk of peritoneal cancer is still very low, even if we don't know necessarily if you had one of these lesions in the first place.
Thank you, Michelle. I think Kelly's gonna navigate the next one.
Right. So we're looking through the questions, and thank you for submitting your questions. There's a lot of important information here. And Michelle, could you explain to us why the risk doesn't go down to 0 after a woman has her ovaries and fallopian tubes removed? Why is there that residual risk? Can you explain that to us?
So probably because we can never get every single microscopic cell. And if there were any abnormal cells or atypical cells, even one cell in the end of the fallopian tube or on the ovary that exfoliated off into the pelvis and may have implanted there, it's possible that those cells could become cancerous down the road. We also don't know what the origin of peritoneal cancer is. So there are theories that we think that it's maybe the end of the tube, the way I just described to you. But what if it's not that? What if it's that the peritoneal lining can become cancerous just like the fallopian tube can become cancerous? And if that happens, there's no way to remove the entire peritoneum. So there's no way to lower the risk completely to 0, but there are ways to reduce the risk lower than that of the general populations or similarly to that of the general populations.
Great, thank you. And should women be followed after they have an oophorectomy? Should they be coming back to you for any type of screening?
So there is no screening for ovarian cancer. There's no screening when you're high risk. We can't do CA-125s and ultrasounds. It doesn't pick up cancer early. And many people say, well, I would just want to know anyway. The problem is that even in the patients who we've done surgery on and found cancer and went back and looked at their CA-125s, which were drawn maybe a week before surgery or 3 days before surgery, the CA-125s are normal. They only start to become abnormal when the cancer has spread. So screening doesn't work for ovarian cancer. Screening depends on the likelihood of somebody having a cancer. So if you can imagine that screening doesn't work when your risk of cancer was relatively high, it especially doesn't work when you've already removed the tubes and ovaries and your risk of cancer is low. So there's no surveillance that should be done after the tubes and ovaries are removed for the risk of new fallopian tube, ovarian, or peritoneal cancer because it doesn't work.
So Michelle, seems like a lot of women have already had a diagnosis of breast cancer. And I know you've already reviewed some of the options available to these women with respect to managing their menopausal symptoms following a oophorectomy. But there's quite a few questions surrounding more natural ways of managing some of their postmenopausal symptoms. Maybe you can talk about some that you're familiar with.
Yeah, so there's good evidence that women who do cognitive behavioral therapy for hot flashes, women who use acupuncture, paced breathing, that all these things can be very effective at reducing hot flashes and night sweats. Similarly, women who maintain healthy lifestyles, so, don't smoke cigarettes, don't use too much alcohol, exercise regularly, tend to have less hot flashes and night sweats in general. So it may not fix the flashes you have, but it may help to maintain a healthy lifestyle to lower just the number of flashes that you may be destined to get in general.
Thank you. That is very helpful. Sorry, I'm just going
I think
through
we will take one last question, Michelle, before we wrap it up. I know people have children at home that have to get back on their classes and things like that. So one of the questions really was about how there are differing opinions on how women should be treated across the country or managed across the country and probably across the world as well. And I did just want to mention that we do have a clinic at Women's College that's trying to help women navigate how they should move forward after they're identified with a BRCA1 or 2 mutation. Can you tell us a little bit about how a woman would be able to come and see you? Many women have questions about how to manage their symptoms, what other alternatives there might be that they may not have been offered by their primary healthcare provider or gynecologist in the community. Can you tell us how a woman can come to the clinic at Women's College to be managed after they have a oophorectomy, or in fact, when they're trying to decide on whether or not to have a oophorectomy?
Yeah, absolutely. So for women in Ontario and really across Canada, we are happy to see you at any stage in your decision-making or treatment pathway in the Familial Ovarian Cancer Clinic. And as I mentioned, and as Kelly mentioned, we have other specialists at Women's who also deal with sort of all aspects of being a carrier. The best way to see us in the Familial Ovarian Cancer Clinic is to get a referral, and it could just be sent to the Ovarian Cancer Clinic, and all of those referrals are triaged. So if we see that you've had surgery already, you're going to be booked with me to talk about menopause. If you haven't yet had surgery, you may be seen by any of the 4 of us who work in the clinic. One of us is an oncologist, one of us is me, and 2 of us are minimally invasive gynecologists. And we all wrote these guidelines together. So we all try and give consistent messaging in terms of advice and counseling. So there's a fax number. It can be found on the Women's College website if you type in the Familial Ovarian Cancer Clinic. I also will just say it now so that if anyone wants to write it down, they can give it to their primary care provider or genetic counselor to get a referral. And that's 416-323-6330.
That's great. And I
And
think
just as a follow-up to that, I'm sorry to interrupt. And yeah, I've noticed a lot of conversation about where people live across Canada and having access. Unfortunately, the same type of clinics are not found across Canada. We're very fortunate to have Michelle and her team here. But for other provinces, I really think continuing to check in with your genetic counselor is probably the best way to help navigate seeing someone to help manage you throughout this, throughout your care.
I mean, we are willing to talk to and see people virtually from all over Canada. That's not a problem at all. There are no other formal centers of excellence, but that's something that's actually on our list of trying to achieve. So we would like to see a clinic like ours on a smaller scale in every major center in Canada. wherever there are gynecologic oncologists, we think that there should be familial ovarian cancer clinics where you can access this kind of information. So hopefully in the near future that will happen. There is a small clinic in Manitoba, in Winnipeg, where they have an oncologist and a menopause specialist. And there is a clinic being developed currently in Vancouver with their oncologist there. They don't have a formal menopause specialist per se, but they do have a lot of interest in managing this.
Okay. Thank you so much, Dr. Jacobson. It was wonderful to start off this virtual series with you. I know we all learn so much from you every time you speak. And I really think that we're fortunate to have you at Women's College Hospital and helping women get through this important stage in their life. Like you highlighted, it is a recommendation that women with a BRCA1 or 2 mutation do have their ovaries removed. And once they do, you and your team are there to support that woman in terms of getting through some of the symptoms that she may experience. So thank you for doing that.
Thanks.
So,
Michelle.
yes. So thank you.
Wonderful overview.
Thank you to all of you for joining us today. I think this is an exciting time as we launch this virtual series. And I would encourage you to come and hear the other presentations that we have going on throughout the year. So this is something that we're committed to continuing. We want to bring you the latest information. We want to bring you the latest research. If you have ideas that you would like to see us cover, let us know, because that's some of the seminars that we could do in the future. So please let other people know that may be interested. They don't have to just be patients at Women's College. We're interested in letting everybody know what the latest research is, and for those that can benefit from this information.
And if, in case you are not already a participant in our research program, a lot of the information that Michelle spoke about and a lot of the work we do here at Women's College is based on a study that was initiated by Dr. Stephen Narod in 1995, in which we enrolled BRCA1 and 2 mutation carriers, and we follow them by questionnaire. And this is what really informs our research and helps us carry out these important projects. So the contact information is listed here. And everything will be posted on our website. I think we'll do a better job at posting the website perhaps at, oh no, well, it's here. It's at womenscollegeresearch.ca. So we will try to have this posted in the next little while.
So thank you so much. And we look forward to seeing you next month for our next seminar. Thank you. Bye-bye.
Thank you, everybody.